Thank you very much for the invitation to speak at the symposium. We've heard some great things this morning, and what I'd like to share is where the rubber actually hits the road in our general practice laboratory, where there's very little control of the subjects, and you can't isolate single variables, but you're actually dealing with whole human people with emotions and subjectivity. So my perspective is very much general practice. It's rather extraordinary that this tiny molecule has caused such a huge controversy in medicine. And it's rather remarkable. We all know about Linus Pauling and his early work and his early challenge to the medical profession. And he had a great adversary in Dr. Victor Herbert. But, you know, one of the delicious ironies in their relationship was that they both developed prostate cancer. And Victor Herbert died at age 69, and Linus Pauling died at age 96, swallowing a large amount of vitamin C for most of his life. One of the other interesting things now that we're in Auckland is that Professor Dick Matthews, who was head of department in my father's department at cell biology, in the early days wrote to the medical council and suggested that vitamin C would be a worthwhile avenue for research, but he was politely rejected. It must have been quite hard for head of department and fellow of the Royal Society. Here are my great heroes here, Linus Pauling and Ewan Cameron. Ewan Cameron, you know about his research in Scotland in the early days. Our background at Northland Environmental Health Clinic, we are a GP clinic. There are 3 of us doctors. And for myself, I started using vitamin C in 1995 for patients with infection and as a support in treatment of their metal toxicity. But in the early days, I had 1 or 2 patients who took me outside my comfort zone, and little by little I began to discover that vitamin C could be very helpful in cancer patients. And I recall one lady in particular in her mid-50s with advanced stage 4 breast cancer, who also had bilateral pneumonia and had been admitted to the hospice locally in Northland. Her family were very keen for her to have intravenous vitamin C, and they Googled intravenous vitamin C for cancer, and they were prepared to take their mother and wife anywhere in the world for intravenous vitamin C. Fortunately, they could just travel a few kilometers up the road to our clinic, and she received vitamin C lying down because she was too sick. And then later in the week, she was too sick to come to the clinic and was given another infusion of vitamin C. Well, at the end of the week, she was discharged. Not to die, but she went home, very much alive. Her infection was controlled, and she lived another 9 months receiving weekly vitamin C infusions further north. Following that experience, I then started to use vitamin C at higher levels of 1 gram per kilogram body weight, or slightly more for males. And that was around about 2010. But I had to deal with a lot of these advanced cancer patients who come with great expectations and hopes. And for any of you GPs who have been involved in this work, you have to sort of somehow answer their hopes with some sort of realism and but nonetheless keep their hope alive. But universally, advanced cancer patients want an improvement of quality of life and, if possible, increased longevity. So I'd like to present the outcomes from our clinic from January 2006 to February 2019. And these figures are current as of 1 week ago, last Friday. There are a total of 427 cancer patients, and you'll see that the bulk of the patients, nearly 60%, have got stage 4 cancer. A few in the early stages, a few more with stage 2, and 8% was 8.7% was stage 3. But you know, the bulk of the patients have advanced cancer. Generally, when I am assigning the stage of the cancer, I take it from the specialist letter where possible, but in some cases the stage is not quite clear, and so there are 49 of the patients with an unknown stage or uncertain. And the data flow for your interest here, a total of 427 cancer patients. These are consecutive patients seen at our clinic, of whom 248 are stage 4 only, and for which we have almost complete data for 241, with 7 patients of an uncertain survival, where they've lost to north and we can't follow them up, and we're not sure if they're alive or dead. But essentially, we've got a very large group of patients now for which we can calculate our survival data for the 70 patients who have had palliative care only, and for the 171 patients who have had intravenous vitamin C and integrative medicine, for which we have calculated our survival statistics. From 2015, I decided to use a tool which would enable a quality of life assessment, and I'll explain that in a moment. So for the last 71 consecutive stage 4 patients, we have quality of life data every week for the patients that have come to our clinic for vitamin C infusions. And just to show you, this is quite a busy slide, but just to indicate that we have a fair representation of just about all of the major cancers that you would see in an outpatient hospital oncology clinic. Firstly, breast cancer, the most common, ranked number 1. Colorectal, 34 cases, ranked 2. Lung is 3rd. Pancreas, interestingly, is 4th. Prostate, 5th, and so on, for the 248 cases. And for those of you that like diagrams and pictures, here you can see a pictorial representation of the same data. So we've got a good spread. It's not one kind of cancer at all, but a good spread of all of those cancers in the stage 4 patients, 248. When you look at the demographics between the palliative care only and the vitamin C patients, there is no difference, or at least no statistical difference, between the age of the patients, 2 years only, between the palliative care, 61 years, and the vitamin C treated patients, 59 years. No statistical difference. And similarly, the proportions of male and female are not significantly different on a chi-square 2x2 analysis. For the quality of life, as I mentioned, what we used from 2015 was the European Organization for Research and Treatment of Cancer, the Quality of Life Core 30 questionnaire. And it's been around for at least 27 years. Probably earlier in the 1990s it was being researched and validated, and the first studies were being published. But it's turned out to be a very useful tool by which you can assess quality of life in chemotherapy research, in novel cancer drug trials, and now in vitamin C research, including at our clinic. What they use is 5 function scores, including cognitive function, physical function, emotional functioning, and so on. 8 symptom scores, including fatigue and pain, nausea and vomiting, loss of appetite, loss of weight, and so on. And 1 global score, which is a composite of all of the measures together. The lowest score is 0, the highest score is 100, with the best quality of life. And there's a small sample there if those of you want to look up, and that includes one of our New Zealand papers. And we've used this, as I say, weekly from 2015. And pretty well most of our patients are used to the idea of filling it in every week as they sit down for their vitamin C infusion. Occasionally in the beginning, 1 or 2 people would forget to do it, and they'd take it home and they'd forget to bring it back. But generally, most of the patients, pretty well 95% of the time, will fill out the questionnaires for us. So we've got some very, very good longitudinal data. And overall, we've got 71 patients at enrollment. 4 of those patients, 5 of those patients are still alive at 24 months. And we've used statistics program to calculate the scores for each of the patients. So here is the summary slide for one of the functional scores. This is the physical functioning. And here you can see at baseline, time 0, you have a certain score and a range. There's quite a range, as you can appreciate. But as you go through treatment, for every 3-month block period, you will see the physical functioning, for example, goes up. It dips at 12 months, and I'll come back to this point in a little while, and then it stabilizes and increases. And those scores are reflected in virtually all of the functional scores that we have looked at. Bear in mind, this is stage 4 cancer patients who are quite sick and with multiple ill health symptoms. So role functioning, again, improves. If you look at emotional functioning, it improves. If you look at cognitive functioning, it improves. And social functioning, again. But you see, each time you get a little dip around about 12 to 15 months before it comes up. And I've thought about this long and hard, and I really can't give you a good explanation for that, but it's something that I've noticed. And maybe it's an anniversary phenomena, but perhaps there's a metabolic changing of the guard. When you look at the symptoms, again, you notice fatigue here drops quite significantly. It surges around about 12 to 15 months, and then it decreases. And this is a very long-term study of these patients. And when I've looked at the stats, and I'll show these to you in a minute, there is a significant difference between the baseline and 6 months and thereafter. And although there is an improvement at 3 months, it is not statistically significant. Pain, again, decreases. And here is the global quality of life summary score for all our stage 4 cancer patients. And again, you'll see that there's a score, a median score just above 50, with an improvement at 3 months. The difference between those two figures is not significant, but thereafter all other global scores are significant over the 24 months for our study. And I've just represented the statistics. It's quite a busy slide, but just again to show you, I beg your pardon, at 3 months it was significant, yeah. All of the improvements are statistically significant, except a slight drop at between 12 and 15 months. And but the global score for all the patients doesn't tell the entire story, and that is that if you divide the 71 patients into 38 patients who are the sickest, the patients who are the most cachectic, with the gross ascites, with brain secondaries, with extreme fatigue, with the lowest scores, in point of fact, these are the patients who do best with intravenous vitamin C. And you can see the improvement in their global quality of life scores during the course of the 24 months. And it's quite striking. And you can actually see this when you compare it with the patients who have started with the higher scores. These are the patients who actually, you could really say, well, vitamin C has stabilized their condition. And again, you see this little dramatic drop at 12 to 15 months before the global score comes up. And if you combine both the low start and the high start, the low start being in the red, the high score being in the green, again, you can see the very obvious, clear separation in those two groups of patients. The point being that no matter how sick the patients are with stage 4 cancer, it is very likely that the sickest ones will be the ones who will respond best to vitamin C therapy. We also use the symptom score, the Core 30 questionnaire, for individual patients. And it's a great tool for monitoring their individual response to therapy and general progress. And this is a lady who presented in October 2013, a 40-year-old lady with a very large parietal tumor, which you can see there on CT scan. And that tumor was surgically removed, and she received adjuvant radiation treatment of 60 gray with temozolomide. And following that year of treatment, she then had 1 good year of symptom resolution. But in late September 2015, she once again developed significant left-sided symptoms. And you can see here, this is an MRI scan of her parietal lobe. You can see the area where the tumor has originally been debulked, but you can see this huge regrowth of tumor right across the midline here into the left parietal lobe as well. There was no treatment offered to her because her original tissue diagnosis was a grade 4 glioblastoma multiforme, and she was given a very short prognosis. Well, she had intravenous vitamin C therapy, and I'm pleased to say that lady is still alive. And you can see here her global quality of life score. In fact, it started reasonably well, and it's been maintained all the way through, again with this little dip at 12 months, 52 weeks. and it's been maintained through. For a second patient, just to show you the progress, here's a patient who had vitamin C here. He then went down to Auckland to receive chemotherapy, and his quality of life dipped. He returned back to Whangarei, and you can see here his quality of life climbing up here, stabilized. At this point, he was admitted to hospital, vitamin C not possible, and he passed away 4 months later. But again, you can see the questionnaire is a very useful tool for monitoring the progress in individual patients. The question then is, does vitamin C infusions give our stage 4 cancer patients increased survival? What we have found is that 5% of our stage 4 cancer patients have survival at 5 years or longer, some without disease progression and some disease-free. And I'm going to show you our Kaplan-Meier log survival and cumulative hazard of data for the 241 consecutive stage 4 cancer patients at our clinic from January 2006 to February 2019. And this is our survival data. You can see here, I'll take you through the slide. The green graph here is the patients who are treated with intravenous vitamin C in green, and the red is those who have received palliative care only. I should make it clear that we are, when I say intravenous vitamin C therapy, it is not a monotherapy. These are patients who are receiving integrative health support with change in diet, with relevant supplements, with attention to micronutrients, with oral vitamin C, and where appropriate, with palliative care, with good pain relief and antiemetics and so on. But the only difference between these two groups is the fact that the patients in green have received intravenous vitamin C therapy. And I should also make it clear that in this group with vitamin C therapy, that includes patients who have had one single intravenous vitamin C infusion, but are so sick they've passed away the next week. And there are several in that category. So they have been included in our data. The stats show that there is a significant difference between those two populations, significant at a 0.045 level on the Breslow chi-square. When you look at the log survival plot, it looks even a little bit more better, so I quite like that plot. But again, you see the same story. And when you do the hazard, cumulative hazard plot, hazard in this case being death, you will see she rises pretty steeply at about 2.5 years and levels off there for the vitamin C treated patients. The median survival doesn't look all that sort of great in terms of the improvement. As you can recall from the graph, the two graphs come down fairly close together, and a large number of patients are passing away in the first 3 to 6 months, and our median survival improves from 6.24 to 7.44 months. But when you look at the mean survival, there is actually quite a significant difference from 7.8 months to 16.8 months. And that's reflected in the very long tail of the cancer patients who are surviving. The overall survival comparison, the stats look quite good. For Breslow, 0.045, Tyrone-Ware, 0.03, and log rank, 0.014. And I'm very grateful to Professor John Pearson at Otago University, Christchurch, for supporting me in using the syntax to obtain my data. And just to show you that I haven't cherry-picked the easiest cancers to treat, here you can see in this quite busy graph, you've got fairly good representative proportions of patients with all the different cancers in either the palliative group or the vitamin C treated group. So breast, 11, 28 vitamin C. For the colorectal, 33 total, 8 have had palliative, 25 IVC, and so on through the different cancer types, more or less following the proportions of the actual cancer types and ranks. And for those who want the pictorial presentation, again, you can see the green bars are the vitamin C treated patients. The grey-yellow bars are the palliative care only. And really the only exception in the group are the ones with lymphoma, who for some reason elected to have vitamin C only, and at least in the ones that visited our clinic. That's probably all I can give you for the stats now. And the talks this morning would have given you some of the explanations for why the patients have an improved quality of life and perhaps longevity. And I think myself that the quality of life improvement is due to improvement in their antioxidant status, and the longevity perhaps is related to some of the other mechanisms here. The extracellular sort of hydrogen peroxide, the reduction of cancer cell glycolysis, epigenetic with the TET2, downregulation of hypoxia-inducible factor 1. And I think also one of the things that I have a particular interest in is the fact that ascorbic acid provides substrate for the salvestrol cytochrome 1b1 activation and cancer cell apoptosis. And in conclusion, I'd like to acknowledge the people who support me, my family, particularly my wife Mary, and puts up with me with my research obsessions, and our clinic staff for retrieving and coding, particularly my receptionist Kim Kennedy in the last 2 weeks. I'd like to thank particularly the staff at University of Otago, Christchurch, Margaret Vissers and Anitra for support and encouragement, for Professor John Pearson for helping get the syntax to get my survival data, and but above all for the patients who have entrusted themselves to our care as we've followed their ups and downs and their challenges. Yes, that's all I've got to say. Thank you.